All right, so we have two major classifications on the type of immunity in the body. We have non-specific and specific immunity. So non-specific means that our immune system will respond to any pathogen, any foreign particle in your body. And remember that when we say antigen, it could be bacteria, fungus, virus, could be cell from another person, right? So anything that is not self. And that obviously is what we have, or we call innate immunity. And that involves all these different parts of the innate immunity, which skin and digestive tract and respiratory tract. So everything that we innate means we're born with it. So everything that comes with us already, it's part of that innate immunity, which is not specific to a particular antigen. And then we have the specific immunity, which is the one that is determined by antibodies and cell-by-cell contact. So it's called cell-mediated immunity. And then the antibody is called humoral immunity or antibody-mediated. But those two are part of our specific immunity, so that when something gets into our body, this huge response is mounted, and we start making antibodies and we start preparing specific cells to kill by contact. So that's the beauty of specific immunity. But when we talk about neutrophils in our blood chapter, I mentioned that neutrophils are the ones that run to the site of infection, sometimes uncontrollably, and then they start to die, and they produce pus. And when you see that, which is not very nice, but it's an indication that our immune system is working, is because of the ability that these neutrophils have to get out of the blood vessel. So in this picture, this is a blood vessel. Obviously, it has endothelium, right? So very thin. So what happens is that they receive this chemical chemotaxis signals that they start to roll, and they kind of like attach to the endothelium. And when they attach to the endothelium and the inside of the vessel, they start to kind of like spread out, and they become very, very thin, so they can go in between the simple squamous epithelium, and that's called extravasation. Extravase, meaning vessel, right? So they're coming out of the vessel, and they're going to go to the site of infection. And as you know, neutrophils are very good phagocytes, means they can do phagocytosis really good, which is just the engulfment of the bacteria or anything for that matter that has entered the body or the site. So that's one of the main things that happen in the non-specific immunity. They just go, and like I mentioned before, that sometimes they go really bad, and so many that then they start to die and accumulate, and that's really what pus is all about. So what happens with phagocytosis is that once the bacteria or the foreign particle gets inside the phagocyte, then lysosomes, which are these little organelles that have hydrolytic enzymes, and by that means they're digestive, they break down things. So what happens is that the initial little vacuole fuses with the lysosome, like you see here, they become one, and then the lysosome with all those digestive enzymes is going to destroy or break into pieces that bacterium or anything that has gotten in. So that's the process of phagocytosis, which you should have learned a long time ago, right? So then is this is the ELISA technique, and this is how we can conduct an ELISA in the process of agglutination. So it's a specific antibody with the specific antigen is going to cause agglutination. And this is the process by which we can determine if somebody has been exposed, if somebody is undergoing the infection, or if they've been vaccinated, for example. You can determine that by agglutination, but it's also the technique that we use to blood type, right? Using commercially prepared antibodies, and then the red blood cells will have the specific little flag for self-antigen that is going to cause the agglutination. So local inflammation, and this will be a question in your exam, number 4. What are the steps in local inflammation? So obviously, first thing that happens is that bacteria needs to enter the skin. Somehow, intact skin is very highly protected. If you have a break, meaning even a scratch, a scrape, or a cut, then that allows for bacteria to enter the skin, and that starts the process of inflammation. So same with pus. Inflammation is not pleasant because it's sometimes painful, but this is a sign that your immune system is working. So you start your phagocytosis, and you have macrophages and mast cells in the tissues. They're going to start releasing those chemicals that I mentioned are attracting those neutrophils to that wall of the endothelium, and they start doing that phagocytosis. Then the other non-specific response that we have is the complement. Complement proteins are, I would say, similar to the blood clotting factors. They're inactive if everything is good, but the minute there's bacteria or something invading our body, the complement system will start activating in a cascade reaction. And the final step in the complement is to create holes on the infected cell, and that will cause lysis, because then water starts to come into this infected cell, and that will finish up with the infected cell. And then the last thing that happens are T lymphocytes. If we have them already sensitized and they're recognizing this bacteria, they will be arriving to the site as well. So what are all the symptoms that we feel in inflammation? So we have warmth, swelling, and pain. Those are the classic symptoms. So if anything is infected, you all have experienced this. You probably feel the area and it's a little warm. There's swelling, and the swelling is what causes pain. So the swelling pushes onto nerve endings, and that's what is causing pain. Now, inflammation recruits more leukocytes, and that's what I was saying with the coming up in droves and causing the production of pus. But the warmth is because there's an increase in local temperature, because that's one of the signs to start killing, right? You all know that heat will kill bacteria. So the warmth that we feel locally is because of that. It's one of the reactions of the body. If we increase the temperature right there, we may be denaturing the proteins of this bacterium, and that will cause them to die. This swelling comes from a lot of histamine that is being released in the area, and histamine is a powerful vasodilator. So the some fluid starts to seep out into the tissues, and that's what causes the swelling. So a little bit localized edema, and whenever you have that, that can press or put pressure on pain, on nerve endings, and that's the cause of pain. So this is what happens at the local level when you have a little bit of infection on a specific local region. And more than once I've had it on my hand. You cut yourself and something happens and it gets infected, and so you, I'm sure, experience the redness, the swelling, and things like that. So this is happens for any infection in the body, inflammation. So if you've been following COVID-19 and some of the news about health in general and what happened to those people that did not fare well, or that they had very hard symptoms with COVID, and they were talking about the inflammation. So the virus not only attacked the lungs, and causing some people to be short of breath and had to be put on a ventilator, but it's the inflammation that was very, very severe. So because of all these reasons, the fever, the swelling, the pain. So, and this is overall, inflammation occurs all the time whenever anything foreign gets into your body. And as the time progresses, then we get that the B lymphocytes are going to change into plasma cells, and they're going to start making antibodies. These antibodies may not be of use for that very localized inflammation, but if the patient encounters the same bacterium later in life, they're going to be protected and they're not even going to feel that like they're undergoing an infection. So this has to do, okay. So this is a nice little illustration of what happens in inflammation. So the bacteria, of course, needs to have a way, an avenue to get into the body. So this is your stratified squamous epithelium, the skin. And of course, there's a cut here. So that's what gives way for bacterium to enter. So you can see here, if this patient already had been exposed to this bacterium, which most likely we all have, then you will have some antibodies that immediately are going to recognize it and they're going to start surrounding the bacterium. And what happens with the antibodies is not that the antibodies kill the bacterium, the antibodies make the pathogen larger, bigger. It makes it noticeable for the neutrophil to come and say, oh, okay, here's the pathogen and I can see it now because it's surrounded by antibodies. Antibodies are large molecules, proteins, and when they surround the bacterium, it makes it larger, and that's what the neutrophil detects, and that's how the phagocytosis occurs. And here you have a mast cell, which are cells of the dermis in the skin. They have granules of histamine. So this is the histamine that is always being released when there's inflammation. The histamine causes the vasodilation. The vasodilation is to bring more oxygen to the area so that we can start healing this tremendous cut that we have here. But it also causes a little bit of the edema in the area, localized region of the infection. So that's why we have swelling, and the increased blood flow also causes the increased warmth that we feel in those tissues when they are inflamed and infected, I would say. So whenever we have an antigen getting into our body, the B cells are the ones that can start making specific antibodies. And they are just specific for that particular antigen. So at this moment in our lives, we have so many different antibodies to a bunch of antigens that we are exposed in our everyday life. So we're not sick all the time, right? So whenever we get sick, it means that you were never exposed to that particular antigen. Or if you were exposed, it's been very long time ago, so that you still have that initial fever, inflammation, swelling, pus, infection, right? But if you have been exposed in the past, you always are going to have what they call memory cells, which are the cells that are going to remember that antigen. And when the antigen gets in the body for a second time, a third time, or whatever times after that, they're going to recognize it. So B cells, when they are sensitized by a specific antigen, meaning, oh, I'm recognizing this is foreign, they're going to produce antigens and they're going to expose them like antibodies. And they're going to expose them this way, like you see here. The antibodies here are the little green Y-shaped structures here. And we can see here how these antibodies are on the surface of the B cell. So at this moment, what happens is that this B cell will start dividing and creating little clones of itself. So a clone is something that is the same, right? Exactly the same. So what happens that these little clones are going to become plasma cells. Now, plasma cells, if you notice, they're still B cells, but they are specifically little factories for that specific antibody. And now the antibodies, instead of being on the surface of the B cell, the antibodies now are going to be secreted out. And the antibodies then are going to circulate in our blood and in our tissues as well. So for the next time we encounter the same antigen, then we know that we're going to be protected, because sometimes you don't even know that you're being infected by the same antigen. At the same time, these little clones are going to create memory cells. And as you notice, these memory cells are very similar to the first one here, which is a sensitized cell that has those antibodies on the surface. So for if in 2 years you encounter the same antigen, then they're going to go over and do this again. They're going to attach the antigen, they're going to start dividing, and they're going to create plasma cells to dump a bunch of antibodies into circulation and the tissues. So when you are, I wanted to show you this picture because it's very telling, and I know I'm going out of order, but so since we're talking about vaccination, some of you have had the vaccine for COVID. This is the purpose of a vaccination, right? When you first encounter an antigen, and here in blue, you have the primary response or first response. This is when you've never seen that antigen in your life. So if you notice at the bottom here is time in weeks after the exposure. So 1 week after, it takes about a week for your antibody to start to grow, okay? So for about a week, and in certain cases 2 weeks, that's when you're sick. The first time that you see an antigen that you've never seen before, you feel all the symptoms, you feel sick, you have the fever, you have the inflammation, runny nose, short of breath in the case of COVID. So for that first week or two, depending on the disease, you feel sick because you haven't built up your antibody titer. Titer means concentration, right? We saw that in the ELISA lab. So, but after that week or two, you can tell that your antibodies increase up to a point. And of course, after 4 weeks, we should all be feeling better. Usually after 2 or 3 weeks, your flu is getting better. And even with COVID, after a month, for people that have not needed hospital stay or things like that, they start to feel better. And the reason is because you made all these antibodies. Then after a few weeks, the antibody titer will decrease, but it will stay at a certain number for many, many years. And more so that what we are going to have at that moment after the infection has subsided is that you have those memory cells, B cells, memory B cells. So that if you see the same antigen for a second time, look at how long it takes for you to create a bunch of antibodies. Almost no time, right? Like 1 day maybe, but your antibodies are going to be so high that you may not even know that you're going through an infection, same infection as you did a few years ago. And then on the second exposure is that you really create a very high titer of antibodies. And look what the antibodies are at week 5, for example. So this gives you also the idea of vaccination. So first exposure, yes, it gives you antibodies, not as high, and it doesn't stay as high after a while. So when we get a second shot of the COVID vaccine, this is what happens. You create a bunch more of antibodies. And now you're going to keep a nice level of antibodies circulating in your plasma and in your tissues. So, any questions so far? I don't have anything on the chat, I don't think. Okay. Are we good with this? Good. I see thumbs up. All right. So all what we've been talking about is what we call active immunity, right? This is when you're exposed to the antigen, you go through the infection, you go through the whole process, you are sick, but you're building your antibodies for next exposure to the same antigen. So that's what it is about the vaccine, right? That's what you want. In most of the times, the vaccines have been giving the patient a dead virus, like the polio vaccine. So they kill the virus, and that's what is injected in the form of the vaccine. So that is enough to elicit that primary response, right? So that if you see the virus a second time, then you can go to your secondary immune response. You don't get sick, you don't get the disease, and you're safe, right? You know, polio was very, very serious because children were, or they had to be on respirators for the rest of their lives, and because it will paralyze the breathing muscles as well. So not only that you've seen pictures of people with braces for walking, but also some of them had to be in a respirator because the respiratory muscles were paralyzed as well. Most of the childhood vaccination like MMR and the chickenpox and other ones, they use what is called a attenuated virus. So it means that the virus is there, it's not dead, but they have taken some of the virulence out, which is the causing serious disease. And so most of the vaccinations that we get as children are that way. And then of course we have COVID, which is using recombinant virus or recombinant DNA and RNA. So the COVID vaccine, the way that it works is that they made messenger RNA, which is the one that directs the synthesis of proteins. What they did is they made messenger RNA that codes for the virus proteins. So you're following me, right? So the vaccine, if you got Pfizer or Moderna, JJ has a different way. But if you got those two, is the one that the vaccine contains the messenger RNA of the COVID, and that's what is injected in your muscle. So you have it on your deltoid, they try to do it. So when that messenger RNA gets in the skeletal muscle cells, because that's how they're injecting it, these skeletal muscle cells are going to start making viral proteins. Those viral proteins, once they're out of the skeletal muscle cell, they're going to be recognized as foreign because they're not our proteins, they're viral proteins. And our immune system is going to start making antibodies against that. Now, I don't know if you know that I'm going to do the whiteboard, but the virus is nothing more than DNA surrounded by a capsule of protein. So all the red is protein, okay? So in order for us to make protein, you have to get the message from the DNA, little piece, right? Then we make the messenger RNA, and then the ribosome makes the protein. Now the protein can be used for inside your own cells or is secreted out. But a virus is not a living particle because it doesn't have the machinery like we do in our cells, right? It's just a little piece of DNA or RNA. There are viruses that are RNA as well. Remember, RNA is single-stranded. But that's it. They have a protein coat and the genetic message. So what is bad about viruses is that they get into your cells and they take over your cell. So now your cell becomes a little virus machine making a bunch of copies of this virus, right? But by themselves, outside a cell, they cannot survive. So in our case, the vaccine that we get is giving us just the messenger RNA. This is the viral messenger RNA. For us, it's an unknown thing. It's a non-self. So when it gets into your skeletal muscle cell, then you start making these viral proteins. And that's what's going to cause our immune system to start making antibodies against the virus. Okay, so that's why people are freaked out. Some people, and by talking about some people, is about 20 to 30% of Americans don't want to get the vaccine because they've heard these weird things that the messenger RNA is going to get into your DNA and it's going to mutate you and make you a, I don't know, a hybrid between COVID and a human. It doesn't work that way, okay? So what we're getting is just the message for the viral protein. When our skeletal muscle cells start making that protein, the immune system says, hey, these are not my proteins. These are not my self proteins. This is something that is considered non-self or antigen. And that's how we start making antibodies. And if you are exposed to the virus a second time, like if you are near somebody that has the infection, your immune system recognizes, immediately we create a bunch of antibodies in our secondary response, and that's how people don't get sick. And if they do get sick, even with the vaccine, it's a very mild case. So you know that the COVID vaccine, what is helping us to do is not die, right? It doesn't mean that you may not get it, you might get it, but it's gonna be very mild, a very mild case. So any questions on that?
I have a question.
Yes.
Why does it take so many years to find out if the vaccine is effective?
It doesn't really. If you think about it, in a year they had 3 different vaccines and many more around the world. So it doesn't really take many years. What they don't know 100% is, will there be any side effects from the vaccine?
Oh yeah, that's what I mean, the side effects.
Yeah, because nobody knows. You have to just pass the time, right? This one in particular passed all stages of approvals. It's just that it was fast-tracked and they tested it on less people than they usually would have if they just go by the natural route. Don't forget that also vaccine production is a big business for the pharma companies, and money has a lot to do with the time it takes for everything to be approved. FDA takes forever to take on a case of review. They fast track it this time because the death toll was so much that they had to do it. But in regular times, it takes about 10 years, I would say 10 to 15 years to come out with a vaccine. Side effects, nobody knows the side effects until they start studying them. The vaccines have shown that they are safe. Even Johnson & Johnson, with the 15 cases of the blood clotting issues, they're coming back with it because it's a very small percentage. There's always somebody that is going to die after a vaccination, always, with any vaccine. With the flu shot, people die. So it's all a matter of assessing the benefit versus the risk. and the benefits are a lot larger in this case and with any vaccine. All right, so active immunity is to be sick. So being sick means you're actively making the antibodies. You're going to keep the memory, you're going to keep some circulating, and a second exposure is going to go unnoticed. Passive immunity is when you're giving the antibodies directly to a person, right? So the typical example is placenta. We can pass antibodies to this fetus. Milk, right? Breastfeeding. You can pass antibodies that way directly to the child. Snake antivenom. Or, for example, when you know that there's been an exposure. So I remember when my kids were little, we received a notice from school that they had been exposed to hepatitis. So what they did is they provided the children with antibodies straight in. So you inject the antibodies and you don't get sick. You need to know if you were exposed, right? So passive means you didn't make the antibodies, you're receiving the antibodies somehow, either by injection or from the mother, right? Let's see, I just wanna, well, aging is the worst. Your immune system decreases with aging. So that's why most cancers appear after the age of 60, right? Autoimmunity is a rare condition. And still to this day, we don't know why it happens, but all of a sudden your immune system is now recognizing your own self-antigens. So for example, like the blood types or the other number of different self-antigens that I mentioned we have that makes you unique, right? You're a combination of your parents' DNA, so that makes you unique, and your cells will all have these self-antigens which are telling the immune system do not attack because I'm one self, right? So at any time in life, it has happened that the immune system stops to tolerate these antigens as self, and they become intolerant, which means they start to react to your own self-antigens. And remember, every cell in your body, not only the red blood cells, but every cell in your body has these little flags that determine who you are. So those little flags are the ones, not only blood type, like I mentioned in the blood chapter, but those little flags that we have as self-antigens, those are the ones that they need to be typed and compared when you do a transplant, right? An organ transplant. So they have to match receiver and donor about 75%, right? Now, if you have an identical twin, you're gonna match 100%. But sometimes a brother or sister, they don't match. So they have to look for somebody else because they have to match those self-antigens about 75%. The other 25%, they take care of with immunosuppressant drugs. Now, for autoimmunity or autoimmune disorders, for some reason, and people don't know why, maybe a stress situation, the immune system starts to attack your own cells. And so some of the more common diseases like that are rheumatoid arthritis, type 1 diabetes, MS, multiple sclerosis, Graves' disease, which is a thyroid condition, pernicious anemia, thyroiditis, psoriasis, and lupus. So these disorders are really bad because, as I said, if your immune system is active, the first thing that happens is inflammation. Inflammation, and you start to attack an organ or something like that, and that can lead to organ damage. So it's complicated, very hard to treat. The only thing most people do, and especially at the beginning when they first start, some of them are very aggressive. They give steroids to autoimmune disorder patients because they have to try to treat that inflammation that is occurring. And sometimes the inflammation is systemic and it attacks several organs, like in the case of lupus, attacks the kidneys, attacks the brain. So it could be complicated. In rheumatoid arthritis, it attacks the joints. So imagine having severe inflammation in every single joint in your body. And that is extremely painful. In multiple sclerosis, it attacks the myelin covering of the nerves. And so that causes the conduction of the action potential to the skeletal muscles. It's interrupted. And in certain cases, MS leads to death because you cannot send information to the respiratory muscles. So they are complicated and they really don't know why it happens. Allergies, we all suffer from allergies, right? And especially these days, pollen is in high quantity these days. And the antigens that cause these exacerbated or exaggerated reactions are called allergens. So they're still antigens, but they cause allergies. And allergies is an excessive response of the immune system. So one is immediate hypersensitivity. So, you know, when you're allergic to cats and you go into a house and you immediately start feeling it, like my son is like that. If he goes into a house, even if the cat is not around, his eyes will swell up. He starts with a runny nose. So it's immediate, the response. And delayed is more like those dermatitis that occur after 2 or 3 days after the exposure. So like poison oak, that if you rub against the plant, you're not going to have the response right away, but it will appear as rash and extremely itchy and swelling and all that. That will happen a day or two later. So this is how we get those allergic symptoms. The allergen or the antigen that causes allergy attaches to the B cell. The B cell starts to make a bunch of antibodies, just like it's supposed to, right? The plasma cell is the little factory. But when it's an allergen, the antibody that is made is immunoglobulin E. Immunoglobulin E attaches to mast cells. And when the allergen gets attached there, which is specific, right? Because this is a very specific immunity, all the histamine granules in this mast cell starts to release histamine. And this is the culprit of all the symptoms that we have allergy to. So what do you have? You have runny nose, you have itchy eyes, you have scratchy throat. All that is because of histamine. So what do you take when you have allergies?
Antihistamine.
Right, and that's the reason, right? But are you curing the allergy? No, you're only treating the symptoms, right? That's why we take antihistamines to just take care of the symptoms, if you will. I think I missed the T cells that I wanted to. Yeah, I missed that. So the cell-mediated response is the one that is mediated by the T cells. So here's a very interesting thing that happens with T cells. Okay, so we have different kinds of T cells. We have killer, helper, and regulatory T lymphocytes. So B are making the antibodies, and we keep memory cells, right, for the second exposure. The T lymphocytes are the ones that are going to kill by contacts, which are called killer. Killer because they attach to cells and they destroy them. So that's why they're called cytotoxic. Cyto, cell, toxic. Toxic for the cell, right? So the killer T cell has little receptors on the cell surface that are called CD8. And so what happens is that when they attach to a specific cell, could be virus or fungus, it could be a malignant cell, cancer cell, or could be cells for another person, right? When somebody rejects an organ, right? So what it means is that T cells, they have to be in contact with the infected cells. So that's why they're called cytotoxic, because they have to get close to the cell, secrete these proteins that are called perforins, and that creates the lysis of the cell, right? The infected cell, but they have to be in close contact. The helper T lymphocyte, they have another receptor that is called CD4. So it's little proteins on the cell surface. So the helper T cells are important because not only they tell the cytotoxic T cell to get activated to go kill by contact, but the helper also helps the B cells to become plasma cells, to make antibodies. So in other words, without the helper T cell, we wouldn't have any immunity because they are telling the B cells to become plasma cells. They're telling the T cytotoxic cells to go kill by contact. So there's two major things that the helper T cells do. Now, long time ago, when we first started hearing about AIDS and HIV, we didn't know why these patients were dying, right? And we didn't know why their T cells will be so low in numbers. So if you have very low T cells, there's no way that you can kill something. There's no way that you can have a productive immune response. So these people were not only dying, but also their T cell level was very, very low. Well, it was discovered that HIV enters the helper T cell. So if you think about it, without the helper T cell, you don't have the B cells becoming plasma cells making antibodies. You don't have the cytotoxic T cells specializing in killing a particular infected cell, in this case, HIV infected, right? So these patients not only were dying, but they were dying from secondary infections. They were dying from fungal infections. I don't know if you read or heard that a lot of HIV patients died because of other infections, not just because of HIV. And the reason was because they didn't have that helper T cell in good numbers to direct production of antibodies and to direct the cytotoxic T cell to go and kill. So now they know, and now that's why now what they're targeting is they are the cocktail of medicine that HIV patients take. I mean, by the way, they can live long lives these days because what they have done is they have blocked the CD4, their medicine that blocks the CD4 or blocks the HIV to enter through this CD4 receptor into the helper T cells, and maintaining that high number of helper T cells is what is allowing these individuals not to get secondary infections and not to die from HIV. And then the last type of lymphocytes T that we have are the regulatory T lymphocytes. And this one's what they're doing. They used to call them suppressors, but in very short explanation is that once the infection has been taken care of, they will tell the T cells to slow down, go back. You don't need to keep killing cells. And so it's a way of regulating the immune response, right? So that's why they think that some people that have genetic problems in the regulatory T lymphocytes may be the ones that are suffering from autoimmune disorders, or that they're more prone in having allergies or suffering from allergies because the immune system doesn't stop responding, right? So this is something that you should remember, that anytime that is an antigen present, both of these two cells are going to be starting to be active. So it's not that one starts and then the other, they're both at the same time. So the B cells will start making antibodies. The T cells are going to start creating this very specific cytotoxic killer T cell so that they can go and attack any infected cell by contact. Now, if you look at helper T cell, you know that they're related to telling the B lymphocyte to create the antibodies, telling the T lymphocyte to create that specific cytotoxic killer cell. So what are antigen presenting cells? So antigen presenting cells are cells that are going to detect an antigen, like you see here, and they are going to take it inside, and they're going to present the antigen on the surface of the cell. So this is an infected cell. This dendritic cell here that it says dendritic cell activates, it is an infected cell because the minute that they put that antigen in toward the outside, that's a little flag to tell the T cell, hey, I'm infected here. So then the T cell, the cytotoxic T cell, will attach to that antigen, and that cell is going to create pores on this infected cell and it's going to destroy it. So that's how the killer T cell or the cytotoxic T cell kills by contact. So what is the core receptors in the helper and killer T cells? So the receptor that we have on the helper, we mentioned, is a little protein that is called the CD4. And then in the killer T cell is the CD8, right? So we come already with these little receptors already. So this helper T cell is going to recognize the foreign antigen on any cell that is presenting the antigen. So presenting the antigen means this cell down here is infected, has processed the antigen, and he puts it out into another protein that is called the class 2 MHC molecule. This is for short for a very long word that is, it's gonna come to me, MHC, histocompatibility, major histocompatibility complex. So it's a long word, so we call it MHC. So in our body, we have two kinds. We have the class 2 and the class 1. The class 2 is always on antigen presenting cells, which are infected cells, that they are exposing that antigen into this little protein. And this class 2 fits exactly with the helper T cell. So this helper T cell now knows that there's an infection here. So it's going to tell the killer T cell to be specialized to kill this cell. Now in the killer T cell, the way that they're going to kill is that they attach to another MHC. This one is called class 1. And when they do that on the target cell, they're going to create all these little holes, and the cell is going to be lysed or killed. That's why it's cytotoxic. So let me see if we have it here. Yeah. So what are the histocompatibility antigens, MHC? So they are in every single body cell on the surface, except the mature red blood cell. So another word for those, you may have heard this ones, is the human leukocyte antigens, HLAs. Has anybody heard of that one? HLAs? HLAs are the flags that I was talking about that we all have as self-antigens, and those are the ones that need to be checked and matched for our honor donor receiver in an organ transplant. So they're coded by different genes. You don't have to know this, but they're called the major histocompatibility complexes. So histocompatibility means compatibility in tissues, which means if you have the same MHCs, then you can receive an organ from that person, right? Or a very close one, so that the tissues are going to be compatible, okay? So there's so many different combinations that's why sometimes your own sibling is not a match, but somebody that is not related is a match, right? So they have to match these MHCs that we all have on the cell surface. So as I mentioned, all cells have the class 1, MHC class 1, except for red blood cells, mature red blood cells. So the class 1 are the ones that are required to present the antigen to the cytotoxic T cells. Then we have class 2 MHCs, and those are the ones that are presented by the antigen presenting cells, like that dendritic cell, or also a big macrophage is also an antigen presenting. Antigen presenting means that they will engulf the antigen, cut it up into pieces, they put it out in the MHC, and now they're telling the immune world, hey, come, because I'm infected. I have all these little flags that are not mine. And that's how the helper T cell can recognize it. And immediately after this, the helper T cell goes to the B cell, and the B cell starts making the antibodies. So here is where you have the interaction between the antigen presenting cells and T cells and B cells. So the killer T cell, I start here because it's easier, only one step, is the one that has the CD8 core receptor. This one is the way that T cells come. And it's going to recognize antigens that are in the MHC1, class 1. So this is a cell that is infected by viruses and is putting these little flags out there saying, hey, I'm infected. Now this cell is unfortunately dead, right? It's infected, it's telling the killer T cell, hey, look, I'm putting the antigen out so you can see it. And immediately the killer T cell recognizes that, attaches to it, and that's the physical contact. And that causes little pores all around it, and the destruction of the infected cell occurs. So this is why T cells, killer T cells are so good, because they can go straight to an infected cell, kill it by contact. Now, for the class 2 MHC, which are the antigen presenting cells, and I told you macrophages are just that, they get the antigen in. Here you see the little red dots. They process the antigen, they cut it into pieces, and they put it out into the MHC2. And this is a signal, hey, this is an antigen in the body that the helper T cell can recognize through the CD4 receptor. They get together, and this activated helper T cell now tells the B cell, hey, you need to start making antibodies for this very specific antigen. So both are working at the same time. The B cells are activated by the helper T cell. The helper T cell also tells the killer T cell, and this is kind of like a chain reaction that is going to help take care of the infection. And I don't have more time, but I think that I did what I wanted to do. Yeah? All right, and look at these ones. These are common allergens. What are these? Mites. And these are pollen grains. They look nice, huh? All right, any questions on our immune system? It's not that bad, huh?
No, it's just that those mites look like a little army.
I know, that's crazy. Ooh, yeah.
Mm.
Okay, so I'm going to